still visible. In the late phase, which is the recirculation phase, around more than 15 to 45 minutes post-injection, you have hypofluorescent of the choroidal vessel and gradual fading and of the diffuse hyperfluorescence. The early phase of ICG, you will see in polypoidal choroidal vasculopathy, you will see a distinct network of vessels within the choroid. So that's the first thing you will see. You'll see the network of vessel as the large choroidal vessels of the PCV network will begin to fill before the retinal vessels fill, and they do fill quite slowly, so at a slower rate than the retinal vessel. Shortly after the network is filled, then you will start to see those polyps as hyperfluorescent lesions, and you can see also in the picture these PEDs. The large arrow, white arrow there is pointing at a margin, at the polyp at the margin of the PED. And then eventually those polyps leak, and they're usually surrounded by, as I said, that hypofluorescent area, which starts to become more and more hyperfluorescent. In the later phases, there is uniform wash out of those polypoidal lesions. Again, another picture, so you can see single or multiple focal nodular areas of hyperfluorescence, which are, usually are seen within 6 minutes after the injection of the ICG, and there sometimes you see an associated interconnecting vascular network, and sometimes you don't. The yellow arrow is pointing at an inactive polyp, while the red arrow with the hypofluorescent halo and is pointing at an active polyp. If you are lucky enough to have a video ICGA in your department, you can see also pulsation of the polyps. This is another picture of another case of PCV, so a color fundus photo showing an orange subretinal nodule where your arrow is next to the optic nerve, and there's a obvious pigment epithelial detachment at the arrowhead, and then the ICGA next to it shows you exactly the area of the nodule area where hyperfluorescence is. And there's a halo of hypofluorescence around the nodule. And you can see a branching vascular network superior to the fovea supplying the polyp. The picture below it is a color fundus photo with a massive submacular hemorrhage at the posterior pole. And you can see the corresponding ICGA demonstrating the area of hyperfluorescence, but we cannot, with the polyp, but we cannot see a BVN or a branching vascular network. So how can we tell the difference between AMD and PCV on clinical exam? Well, in AMD, usually in the fellow eye or in the same eye, you'll have drusens, you'll have RPE changes, whether hyper or hypopigmentation, you'll have fibrosis. PED can be seen at both, but more with PCV, especially the hemorrhagic PED type. And in AMD, you'll see foveal hemorrhage. In PCV, you'll see those multiple orange colored lesions that I alluded to, and a peripapillary location. Although the majority of Asians have a macular location, absence of drusen, and as I said, hemorrhagic PED. So this is a picture of an AMD patient just for you to differentiate between them. And the black arrow is pointing at, a lot of residents ask me in the clinic or used to ask me in the clinic about RPE changes. So this is a very clear picture of RPE changes where the black arrow is, and the white circle is small drusens. The left pictures are disciform scar with fibrosis from advanced wet AMD. Another picture again of AMD patient, and you see the subretinal hemorrhage, as opposed to PCV, where you see the above picture, the orange, red subretinal nodules, and you can see serous neurosensory detachment, and in some cases, massive subretinal hemorrhage, serous sanguineous PED. and peripapillary location also should make you always think of a possibility of PCV. Again, there are multiple lesions and absence of large or soft drusen's in the fellow eye. On OCT, what are the features that can help you differentiate between both entities? So in PCV, you should think of PCV if you see a multi-lobulated or notched pigment epithelial detachment, sharply peaked pigment epithelial detachment. And if you can see those, the two arrows at 90 degrees, it tells you the angle of how large the PED is. And there's that curved arrow where you see a hyperreflective ring underneath your pigment epithelial detachment. There's subretinal fluid, and there's the famous sign, the double layer sign, where you can visualize the BVN in this. So as if your RPE is split into two layers. The inner layer is the hyperreflective irregularly elevated retinal pigment epithelium, and the outer layer is the inner layer of Brooks membrane, so the double layer sign. So these are the OCT features that may alert you to think of the possibility that you are dealing with PCV. What about CSCR? Well, we all know that CSCR is due to focal leakage from one or more defects at the level of RPE. And what happens is that there is accumulation of transparent serous fluid from the choriocapillaris into the subretinal space. And we know that there is also a disturbance in the microcirculation of the choriocapillaris, which leads to the leakage in the sub-RPE. So a combination of choroidal hyperpermeability and impaired RPE function will lead to pooling of the fluid into the sub-RPE. Eventual leakage happens through retinal pigment epithelium to the subretinal space. And as you see in this ICG down on the left, there's hyperpermeability of the choroid with multifocal choroidal hyperfluorescence patches. So these are the important features that may help you differentiate between these diseases that are all in the same disease spectrum. Unfortunately, there remains no widely accepted set of criteria to diagnose PCV. The Japanese study group guidelines suggested a diagnosis of definite PCV if you have protruding elevated orange-red lesions on fundus exam and you have a characteristic polypoidal lesion on ICGA. A probable diagnosis is made if you see a BVN on ICGA, but in addition, recurrent hemorrhagic or serous RPE detachment. This is a very interesting study that looks at the sensitivity and specificity of potential diagnostic features detected using fundus photography, OCT, Fluorescein for polypoidal vasculopathy. And you can see the reference down there if you want to look at it. So if you have if you find at least 2 of the 4 criteria on the left, so hemorrhagic PED on exam, so you need to examine the patient, multi-lobulated or notched PED on OCT, sharply peaked PED on OCT, and a hyperreflective ring underneath your pigment epithelial detachment on OCT, then 92 out of 100 cases will have PCV. If you find only 1 or none of those criteria, then 95 out of 100 will not have PCV. Kwamura and Yuzawa et al. Identified 2 subtypes of PCV based on ICG and SD-OCT findings. Type 1 is the polypoidal, so they actually divided them according to the presence or absence of BVN or branching vascular network as feeder vessel from the polyp lesion found on ICG. So type 1 is the polypoidal CNV, which consists of both, you'll see a feeder and a draining vessel, whereas type 2 is the typical PCV, where you lack both feeder and draining vessel, and you only see the polypoidal lesion. The presence or absence of the BVN usually is determined within the first minutes starting from the injection of ICG, so sometimes it is difficult to classify them. Again, other picture of type 1 PCV, the polypoidal CNVM, and you can nicely see that feeder vessel there. and type 2 typical PCV. Other cases of subtypes of PCV. So there are two different cases. The one on the left shows you the interconnecting channels superior temporal to the fovea where the oval outline is. So there's, this is type 2 or typical where you lack your BVN, and the picture on the right is an ICG demonstrating characteristic branching vascular network centrally where those small arrows are, and you see the polyp superior and inferior to the network. So why is it important to know those subtypes? Because it does influence the outcome, the clinical outcome of those patients, and the treatment response to PDT varies between them. So the figure on the right is from the EVEREST study, and they did classify the patients according to if they had a BVN or not, and then if it leaked or not, as type typical as A, polypoidal B, and polypoidal C. So type A had the best visual outcomes in terms of achieving good vision, and type B had an intermediate outcome, and type C had the poorest outcome. So that is the classification they used in the EVEREST study. And why type 1 has a poor outcome? Because they usually have larger lesion size due to the larger and more distinct BVN. They do have smaller than ICG, so the response is lower to PDT and compared to type 2 or typical PCV. And this suggests that we need to adopt a standardized diagnostic and classification criteria for PCV, which unfortunately is still lacking, which may help us individualize the treatment for these subtypes. So what are the treatment options that we have in PCV? So focal laser, anti-VEGF treatment, and PDT. Focal laser is usually reserved for extra foveal or extramacular polyps. It doesn't cost much, but you need to combine it with anti-VEGF because it won't take care of the BVN. It will take care only of the polyp unless you photocoagulate the whole lesion. And then you have the disadvantage of patients complaining of scotomas where they see that laser mark. And of course, RPE atrophy and recurrence also. Anti-VEGF therapy, so the latest evidence from the clinical trials that I will go over in the following slides, EVEREST II and PLANET study suggests a benefit of improved vision, and there's no need for an ICGA. It does cost a lot, you need multiple injections, and there's a low polyp closure rate, around 30%. PDT stabilizes the vision by 80%. So VPDT or verteporfin PDT causes a regression or resolution of the polyps by its angio-occlusive mechanism of action. And so there's a high polyp closure rate. The disadvantage is that it does cost more than laser. You have the complications of PDT. As we all know, there's subretinal hemorrhage, recurrence of PCV, and in large lesions, you might have vitreous hemorrhage and bleeding. And you might need several treatments. So I put this slide because a lot of you won't be able to see PDT as we don't use it, or might see it during your residency a few times because we don't use it much with the anti-VEGF era. So this is on the left grading diagram where we it shows you the location of each polyp and with the diameter of each polyp. And then the image on the right another grading diagram, which outlines the entire polypoidal vasculopathy lesion in green, and then you have the best fit circle in yellow, the yellow circle, which is used to calculate your greatest linear dimension, or GLD. And what we usually do is we choose, when we treat a spot size larger, 1,000 microns larger to your GLD. Larger, 1,000 microns greater than your greatest linear dimension, because you want to make sure you're covering the whole lesion. And usually, as you all know, verteporfin is administered into venously in an infusion over 10 minutes, and then you wait 15 minutes after the start of the infusion, you apply your laser. And you advise patients to avoid direct sunlight for the next 48 hours. What are the side effects? The porphyrin side effects, photosensitivity, the injection site side effects, extravasation, and there's transient visual disturbance and loss after PDT, RPE tears, post-PDT hemorrhage, secondary CNV, which can be devastating, and choriocapillary blockage. So there is unfortunately a poor long-term PDT outcome. This may be because of persistent and chronic exudation of the BVN, which doesn't usually respond to the PDT, but so the PDT really takes care of the polyps, but not the BVN. And then you have the recurrence, which is very typical in PCV. There's no evidence that the complete polyp regression prevents future recurrences. And if every recurrence requires a repeated PDT, then you have cumulative damage, which is inevitable. And you have progressive RPE atrophy, progressive choriocapillary dropout, and of course, secondary CNV. I'll be talking about a few landmark studies in terms of PCV treatment. It might be a little bit advanced for the PGY1s, but you should start reading studies and getting used to critically appraise them, and as this is what you will do in your future when deciding your treatment modality. So we'll start with the PEARL study. PEARL was a prospective 1-year open-label single central trial, and of note, it was an investigator-initiated trial. So when I say investigator-initiated trial, I mean it's a physician had a research question and he wanted an answer, so he asked a drug company to help him. And in that case, it was Genentech in the US. This study was designed to evaluate the efficacy and safety of monthly ranibizumab in patients with PCV and active exudation or hemorrhage. The primary objective was stabilization of vision, so not to lose more than 3 lines of ETDRS chart. It was around 12 patients. They had ranibizumab 0.5 milligram monthly for a year, and the mean change mean visual acuity change from baseline was 10 letters at month 12. None of the patients had lost more or equals 3 letters, 3 lines of ETDRS chart, and there was complete resolution of subretinal hemorrhage and macular edema in all patients. But polyp regression was observed in around 38% of eyes. The EVEREST study was funded by Novartis. So again, it's important to know if the studies are funded by drug companies. It was the first multi-center randomized controlled trial on PCV. It was based on clinical central reading center grading using a confocal scanning laser ophthalmoscope-based ICGA, and that's why the photos in the study are really nice, and I advise you all to go over it. Under the EVEREST criteria, PCV was diagnosed if there's presence of subretinal focal ICGA hyperfluorescence appearing within the first 6 minutes after the injection, plus at least one of the following: a BVN or a branching vascular network, a pulsatile polyp, nodular appearance when viewed stereoscopically, a presence of hypofluorescent halo that I alluded to previously, or in subretinal nodule on color photo, and or an association with massive submacular hemorrhage. So the primary objective was they wanted to demonstrate that PDT with or without ranibizumab is better than ranibizumab alone in achieving complete polyprogression measured by ICGA at 6 months. So it was a 6 months study. So you see the 3 arms, a combination arm, a PDT arm, and a ranibizumab arm. The demographics of the 3 treatment groups were well balanced for ocular characteristic. Numerical differences were observed with respect to the baseline mean vision, mean age, and CRT and vision. But the median polyp area was similar across 3 groups. And as we see, the primary endpoint at 6 months, PDT with or without ranibizumab was superior to monotherapy in achieving complete polyprogression. A trend to fewer ranibizumab treatments was observed, obviously, in the combination arm versus the monotherapy arm, 3.9 versus 5.2. And PDT with or without ranibizumab was found to be superior to ranibizumab monotherapy in achieving complete polyprogression, although ranibizumab monotherapy showed 28.6% complete polyprogression and almost 62 partial polyprogression. This study also showed that all of the 3 treatment groups were similarly effective in improving vision over 6 months, but the study was not powered to demonstrate statistically significant differences in best-corrected vision. Combining PDT with ranibizumab reduced the number of injections, as I said. Now, EVEREST II was a much larger study. It compared the efficacy. It had 2 arms, so the efficacy of combination versus monotherapy. 322 symptomatic macular PCV patients from 42 sites, 7 Asian countries, these are the results. So ranibizumab monotherapy was statistically inferior to combination therapy in achieving the polyprogression. You can see the comparison between EVEREST 1 and 2 in these slides. And ranibizumab monotherapy achieved modest best-corrected vision, but with the combination therapy, these gains were much notably higher. The first-year results concluded that combination therapy was superior in best-corrected vision and complete polyprogression while requiring fewer injection. The 2-year results were even better. Visual gain was 9.6 letters in the combination group compared to 5.5 letters in the ranibizumab monotherapy group. And this was highly statistically significant. The percentage of complete polyprogression at 2 years was more than double in the combination as compared to monotherapy. These outcomes were achieved with a reduced number of injections, of course, in the combination arm, and there were no safety issues related to the treatment. The next study is the VOLT study. It was a prospective interventional case series of 40 treatment-naive patients with PCV treated with aflibercept according to the label, so 3 monthly doses, then followed by 2 milligram every 8 weeks. The primary outcome was the proportion of patients maintaining vision at month 12. And as we see from the chart there was a mean visual gain of 9 letters at 1 year. 87.5% of patients maintained their vision. The CRT decreased by a mean of 111 microns, and 60% of patients had dry retina, and 67% of them had complete polyp regression at 1 year. And this was consistent with other studies such as Formosa and Apollo study. The PLANET study is a study that is sponsored by Bayer. It was a 96-week randomized double-masked sham-controlled study that was conducted at 62 sites in Asia and Europe. The aim was to investigate the efficacy of aflibercept, EYLEA, injection, and it compared the EYLEA or aflibercept monotherapy with the other arm was a rescue PDT. So not like the EVEREST, it was a combination arm. It was actually a rescue PDT treatment. And here's the study design of the PLANET study. So 333 patients were enrolled, and they did initiate their 3 monthly injections. At week 12, 318 patients were randomized to one of two groups, into the aflibercept 2 milligram plus sham PDT group, which received only aflibercept monotherapy, or the aflibercept with a rescue active PDT group. From week 12 to week 52, all patients who did not qualify for rescue were treated with fixed aflibercept every 8 weeks. So they were extended. And if rescue criteria was met, then patient received the aflibercept every month, plus the sham or active PDT according to which randomization arm they fell into. From week 52 to 96, patients not meeting the rescue criteria were able also to be further either affixed to every 8 weeks, or even better, treat and extend a regimen. And the treat and extend regimen was to extend 1 to 2 weeks according to the investigator's discretion. What was the qualification criteria for the rescue treatment? So to qualify for the rescue treatment, this was evaluated at week 12, as I said, and every subsequent visit, and required a low vision gain together with clear evidence of disease activity. So in details, if you had best vision of 7.3 letters or less, and best corrected visual gain from baseline of less than 5 letters or between 5 to 10 letters, as long as the investigator considered that PDT could be beneficial. Additionally, it also required new or persistent fluid on OCT, as we see, and evidence of active polyp on ICGA. So if there was evidence then of active polyp, then they would qualify for the rescue PDT treatment. In the Planet, PDT was available, as I said, as a rescue treatment in patients who met the criteria. Only 6% of patients met the criteria for the rescue PDT treatment at week 12. So mandating PDT at baseline may result in over-treatment of a large number of patients. That's what the study concluded. As we see here, more than 80% of patients did not require rescue treatment. At week 52 across study arms, fewer than 15% of patients required the PDT. The proportion of patients requiring rescue treatment over 12 months was comparable between the monotherapy arm and the combination therapy arm, as you see in the figures. So the final 2-year results of the Planet were that aflibercept monotherapy for the treatment of PCV resulted in an improvement in best corrected vision of 10.7 ETDRS letters over 96 weeks. This is the biggest improvement in all the studies that I've mentioned. At week 96, more than 80% of patients in the aflibercept monotherapy arm and aflibercept plus PDT groups had no evidence of active polyp on ICGA, and 83% of patients did not require rescue treatment over 96 weeks. So the addition of PDT did not really show any additional functional or anatomical benefits in this study, in this aflibercept study. And during the second year, of course, the option of treat and extend did reduce the number of patient visits and total treatments. There were no safety issues in the study. So after talking about all these studies, what is the practical way to deal with PCV in your clinic? So if you have, and of course, we need just one thing to say is that with regards to selecting the anti-VEGF injection, between ranibizumab and aflibercept, we need a head-to-head comparison trial, which can pave the way for a much more accurate conclusion. So if you have ranibizumab in your clinic, according to the EVEREST II, then you would go with a combination therapy as opposed to a monotherapy. So you give 3 initial monthly, followed by PRN, ranibizumab, and you combine it with PDT. If you have aflibercept, then you would give 3 monthly doses, then followed by every 8 weeks, according to, of course, to the response of the patient. And this is based on the Planet study. And the average number of injections, if you're doing ranibizumab with PDT, then it's 5 in the first year, 3 in the second year, and aflibercept, usually you will need 8 in the first year and half in the second year. Thank you. I hope it wasn't too long. Hello, can you hear me?
Yeah, thank you, Dr. Fadwa.
Mm-hmm.
It's surprising how aflibercept, we all know how aflibercept alone is better than ranibizumab alone. But for you as a practicing physician, would you, which treatment protocol would you go for if you had all?
So if I had all,
machine.
sorry, again?
If you had ILIA, Lucentis, and the PDT.
I would go with the aflibercept. I would go with ILIA.
Yes.
And if I need to do a rescue PDT treatment, then in general, even in AMD, when I have large pigment epithelial detachments, I usually I'd rather use aflibercept.
Yes.
And again, I have no financial interests to disclose.
Yeah. Any studies you have looked into regarding OCTA utilization for PCV?
OCTA again?
OCTA in PCV?
OCTA, you mean subtypes of PCV?
Yeah, angiography. Is it equally effective as doing ICG, or is it better?
So you remember the study that I mentioned that looks into the sensitivity and specificity of, it actually looked into fundus features of detecting PCV by fundus photography and OCT, not OCTA, and Fluorescein angiography for PCV. So if you had a hemorrhagic pigment epithelial detachment on examination and a multilobulated or notched pigment epithelial detachment on OCT with a sharply peaked PED and a hyperreflective ring underneath your pigment epithelial detachment, then you are very likely to have PCV. 92 out of 100 cases will have PCV. And if not, then if you don't have any of those criteria or only one, then you probably are dealing with AMD.
Yes, great.
Any questions from the students? Are they muted or?
I think
the residents, I mean, no?
I think you can unmute them if they had questions. Questions, Fadwa?
Yeah.
الله يعطيك العافية دكتورة فدوى، ما تكسرين.
أهلين. طيب الله يعطيكم العافية جميعا، مبارك عليكم الشهر. شكرا للأسئلة، الله يحفظكم.